All right, so our next speaker is Maynard Phelps. He's going to be talking about medical emergencies in the dental office. Maynard, you want to go ahead and take it from here?
Sure. Good morning, everyone. Um, my lecture should be a more of a review than the previous lecture, which was full of useful information, but um, you know, this is more pertinent when we actually get back into the office and are able to see patients on a regular basis. Just as an introduction to myself, I'm one of the newer associates with Virginia Oral and Facial Surgery. Um, this is Detroit, Michigan, which is where I am originally from. Um, and just a little background about myself. I went to the University of Michigan for undergrad. I went to Harvard for dental school and did my oral and maxillofacial surgery residency at Ohio State. And I've been in practice as an oral surgeon for about 9 years. So I'm relatively new to the practice, but been doing this for a while. This is a place I wish I had lived, which is Kauai, one of the islands in the Hawaiian chain, but unfortunately I'll have to make my way there at some point in the future. So a little bit more about myself. I am married to Joy Phelps, who's a pediatric dentist in Sandston, and many of you may know her already. We have 4 kids, 2 boys, 2 girls, and recent adoptee. Well, we've had our dog for about 2 years now, and she's roughly 3 years old. And we live on a farm, which is much different from where I grew up in Detroit. But we keep chickens in addition to our dog. And I guess my son recently caught a lizard, so we now have reptiles in the house. And when we're not tending to our animals, I am usually out in the yard tending to my plants. All right, and speaking of the farm, this is sort of a controlled burn, which could easily result in an emergency, as you can see. My son is there in the background, sitting on the fence, ready with a hose. I have a hose on my end as well, but as you can see here, this could easily become an emergency. And this is the situation with some of our patients who come in very sick, and we feel equally as nervous with treating them. So just as an outline for this lecture, we'll go over several different emergencies that you can have in your office. This would include an asthma attack, allergic reaction, which could lead to anaphylaxis, an opioid overdose, seizures, syncope, hypoglycemia, aspiration, and of course, possible cardiovascular emergency. So it never hurts to be too prepared. Found this ad at the back of, I think, of Fortune magazine or Forbes magazine. But in any event, this shows a schoolgirl who is ready for action in case her school becomes the site of a school shooting. The risk of her having such an event is much lower than the risk of us having a medical emergency in our office. So we need to be even more prepared. In terms of office emergencies, I noticed a policy in our office and probably most offices. If the staff feel that there's an emergency situation, they should notify the doctor first before, of course, dialing 911. It is useful for your office to have an emergency kit. These can be purchased already assembled, like you can see on the picture here. You could also very easily make your own with the same materials. Some of the kits have a subscription where they will replace the medications as they expire, which makes it a little more convenient. In every emergency situation, you can always apply oxygen or give oxygen, place monitors, and of course, record the emergency as it happens. So in this sample emergency kit, there's several things here. This is probably adequate for most dental practices who do not do sedation. Obviously, if you're doing any type of sedation dentistry or anesthesia, general anesthesia, you will want to have a more comprehensive kit. But in this sample, at least, there's epinephrine, albuterol inhaler, Narcan, Benadryl, nitroglycerin, aspirin, icing, ammonia inhalants, and syringes, which I mean, our office has plenty of syringes because we do sedation, but I understand most dental offices probably do not. So that's a useful thing that's found in this kit that you can, of course, easily order on your own. So speaking of the 911 call, this is, you would hope that you could just pick up the phone, dial 911, and says, someone's dying, I need help, and hang up. Because in a true emergency where you're calling 911, every second you spend on the phone will seem like eternity. And it would be a reasonable assumption that they would know your location by where you're calling from, and that they would dispatch an ambulance immediately. However, that is not the case. Typically, during a 911 call, they will want to know the call type. Is it a drowning? Is it a fire, vehicle accident, gunshot wound? So they do need basic information before they can put someone through to you. They'll need to know the location. Your location is not always correct based on your phone number, and it's even less correct if you're calling from a cell phone. They'll need to know the name of your practice and address, of course, and they'll need to know some basic information about the patient, so at least the EMS crew can be prepared. So this is a sample checklist. If you're a small office and most of your clinical staff are going to be with you, with the patient during an emergency, it can be helpful to have a form like this to give to the front desk staff so that they can make the call. And on this form, it just has the basic information that we reviewed on that previous slide. It's important to note that you can request that the ambulance come without lights or sirens, particularly if the patient is still conscious and breathing and not otherwise at immediate risk, for something bad. You can also have them come to the back door if that is going to be less obvious to your other patients in the waiting room. This is a sample record form so that you can record what has been done for the patient since the emergency began. This is just a sample. If you already have an anesthesia form, then that would be even better. But basically, you will want to give the EMS crew an idea of what treatment has been performed, what has been successful, what your working diagnosis is, and they'll also want to transfer that information to the emergency room providers. So this is an easy way to keep track of it if you don't have this form already. So in an office emergency, is always good to keep a cool and level head. This, of course, is not easy to do if you're worried about your patient, but definitely taking a few seconds to decide on the best course of action is worth it. I've been in emergencies where that wasn't done, where people did panic, and the patient didn't have the most optimal outcome. So we can, let's just jump right into our first office emergency. We'll talk about asthma. This is a condition that lots of patients have. It's a chronic respiratory illness. This is a situation where the airways are chronically inflamed and narrowed. Patients can often are asymptomatic on a normal day, even though their airways are compromised. But at certain points, they can have an asthma attack, which of course is characterized by wheezing and shortness of breath. Some of the triggers for an asthma attack are medications that our patients will commonly take to treat dental pain, such as aspirin and ibuprofen. Certain chemicals, environmental allergens, smoke, exercise can also serve as triggers. But something that is pertinent to our daily practice would be upper respiratory infection, which is very relevant to what we are going through right now, and highly emotional states. At least for oral surgeons, most of our patients come in, convinced that they are going to be in pain. So they are anxious, stressed, nervous, and those states can all lead to an increased risk for an asthma attack. So of course, prevention is key to dealing with asthma, as it is with most medical emergencies. You'll want to know what the precipitating factors are for your patient. If it's exercise induced, if it's cold weather induced, and it's wintertime, of course, that will put them at greater risk. You'll want to know how effective their medications are, if they've ever been hospitalized for asthma, and of course, if they've ever been prescribed systemic steroids, because that would be a sign that their asthma is fairly severe. And of course, asthma attacks are characterized by most commonly wheezing. Generally, the patients can inhale air without a lot of difficulty, but exhalation is difficult. So they feel like they cannot catch their breath. And eventually, if the asthma attack progresses, they won't actually be able to move air at all. So as with any medical emergency, giving a patient oxygen is always a good first step. There are a few very specific cases where giving a patient oxygen may not be optimal, but I would say for the vast majority of any emergency, giving oxygen will be beneficial. And even in those few exceptions, it usually doesn't do much harm. Try to get a rescue inhaler to the patient as early as possible. The earlier you can treat an asthma attack, the more likely you are to succeed in stopping it. If a few puffs of the inhaler is not helpful and the patient continues to be in distress or deteriorates, then of course you will want to consider calling 911. One medication, aside from the inhaler, that you would have in your emergency kit would be epinephrine. This can be both in a vial or in the form of an EpiPen. The EpiPen is easier to use, it's quick. In an emergency and a panic, you don't have to measure out anything. You can just go ahead and administer it to the patient. The vial of epinephrine, the 1 to 1,000, is useful if the EpiPen is not effective or if you need a repeat epinephrine dose, you'll still have it available. So the EpiPen is fairly, commonly used. You can get it as a prescription. It would be good to have in your office. You could also write a prescription for yourself or one of your staff, and they can pick it up, and you can get it cheaper that way for your emergency kit. Essentially, you aim for the anterior lateral thigh. So the kid in this picture on the left is basically demonstrating the use. Usually you take the blue cap off, press it against the thigh, and a syringe will inject for a pediatric patient 0.15 milligrams of epinephrine, for an adult 0.3 milligrams. The demonstration I have here on the right just shows where the major muscle groups of the thigh are. So if you go strictly anterior, you will likely hit muscle, although there is an area where there's more tendon and fat than muscle. If you go slightly more lateral, you pretty much have a long stretch of muscle tissue to inject into. You can use an EpiPen through clothing if needed in a dire emergency. It's also important to note that if you miss the muscle, if you are so nervous that you inject it into the subcutaneous fat or into a vessel, it will still be delivered to the patient. So placement is important, but not the end of the world if you feel like you didn't actually get the muscle. So epinephrine, this is one of the vial I mentioned earlier, the 1 to 1,000. This is basically our body's own crash cart, which is why it's useful in most emergencies. It sets off a cascade of a bunch of other chemical mediators, which we don't have to go into, but basically it prepares our body for a fight or flight response. This is a copperhead, which I walked right past on a field on the farm. You can tell it's a copperhead because it's a beautiful snake. It has a triangular shaped head, which lets you know that it's venomous. It also has a fairly short but squat body, which is very typical of venomous snakes. And the only reason I knew it was there is because after I had already passed it, I heard a thump on the ground, which was it giving me a warning strike. So of course, at this point, my body is releasing lots of epinephrine, knowing that I was that close to a venomous animal. And just by comparison, this is a black snake. These are completely harmless. I'm not nervous at all about handling snakes, but I am nervous about venomous snakes. So what happens to your body when you when it releases epinephrine, the hairs on your body will stand taller due to the action of the erector pili muscle. In an animal, this would be useful because it would make the animal appear larger to the possible threat. Humans, not so much. Of course, for me, I don't have hair on my neck, but if I did, they would have stood when I saw that copperhead. The epinephrine will also cause your liver or make your liver release glucose into the bloodstream. That's going to serve as more energy for your body to take quick action. Dilates your pupils and also has an effect on your upper eyelid to widen the actual opening. And this allows you to take in more of your environment as you prepare for serious action. And then, of course, it increases your heart rate. It increases the efficiency of your heart, and it also dilates your tracheobronchial tree, which basically allows you to take in more air, have more oxygen to feed your muscles, which are preparing for action. In terms of epinephrine's effect on the blood vessels in the skeletal muscle and the heart will dilate, and this is so that they can get more oxygen, to prepare for whatever action is about to take place. The blood vessels in the digestive tract will have an opposite reaction to epinephrine, in which case the vessels will constrict because your body is not concerned about digestion when it's in a survival mode. So, and of course, this is something that we use to our advantage on a daily basis when we give local anesthesia with epinephrine. Since the mouth is part of the digestive tract, when you inject epinephrine with your local anesthesia, the vessels constrict and allow that local anesthesia to remain in place for a longer duration. So with these effects, our body is basically pumped and ready to go. We're ready for some immediate life-saving action at the expense of all other body processes. So basically the epinephrine will tell the lungs, I know you're reacting to something in the environment, but basically we need to be able to run because there's a more immediate threat. And this will cause hopefully in the case of an emergency, cause the airways to open back up as it refocuses your body's attention towards a more immediate threat and allow the patient to breathe again. Our next reaction we'll talk about is an allergic reaction. This is something that we could also see in our office, in particular patients with latex allergies who, either the staff forgets to notify the doc or the doc forgets that the patient has an allergy. And in this case, if the patient is having a reaction, it will often present with a rash. Patient can develop swelling of the perioral region, especially extending more worryingly towards the throat. Later, the patient can have difficulty swallowing, maybe have some hoarseness, which is an indication that their airway is being compromised, and eventually even develop wheezing, which is similar to the asthma attack. Later reactions could be vomiting, diarrhea, pale or red face. Initially, your allergic reaction will cause your skin to turn red from the blood vessels dilating. Eventually, if you move into anaphylaxis, the blood pools into secondary spaces and you actually don't have enough blood flow to see the redness, and the patient could essentially become pale at that point. And of course, if left to progress, patient can lose consciousness. So the picture here, the boy on the left, just shows what the periorbital edema will look like on a patient having an allergic reaction. Picture on the right shows urticaria. You can just see the splotchiness of the skin. It's red due to vessels dilating, but again, as the patient moves into anaphylaxis, that color change can actually lessen. And it is of note that a person with darker skin, the urticaria can actually appear more as light areas. So raised light areas on the skin would be essentially the same manifestation that allergic reaction. So during, if a patient is having a mild allergic reaction, you can give Benadryl, either the oral form or as an intramuscular injection. If they're having a severe reaction or the Benadryl has not been effective, you can use an EpiPen. And the EpiPen typically will come in 2 doses, 1 pediatric dose, 1 adult dose. It makes it easier to sort of just grab in a time of emergency. You can give more than the adult dose in the EpiPen, but you would have to open that 1 in 1,000 ml vial for that. Another reaction which we could see in our office would be an opioid overdose. These patients, here you can see the track marks on this patient's arm, but of course someone with an addiction will use whatever form of the opioid they can get their hands on. So they may take pills, they may smoke, ingest. So not every patient is going to have these obvious signs, but of course if they do when they're unresponsive, you can kind of get a better idea of what their emergency is. These patients will have constricted pupils, depressed respiration, and of course would be slow to respond or completely unresponsive. So this is usually an easy fix if the patient is having a narcotic overdose. You can get Narcan as a nasal spray. It also comes in an injectable form, but I think this form is easier to use for most people, in particular in an emergency. It's important to note that if someone is not having an opioid overdose, the Narcan will have very minimal effect on them. So if your diagnosis is wrong, if they're unconscious for a different reason, if you give the Narcan, you won't cause any harm, and then you can just move on to the next possible diagnosis for that patient. In someone who is having an overdose, though, they will wake up in pain, very irritable. They may have nausea and vomiting, increased heart rate. These are all signs of basically drug withdrawal, which you will give them in an instant with the Narcan spray. But that's definitely better than them, suffering from an overdose. Next, we'll talk about seizures. Patients can have seizures in the office, of course, especially if they're not under control. This is just like the asthma patient. This will be one where you can sort of get a history from the patient. Some patients have well-controlled seizures. Some patients are in the process of titrating medications and may even have seizures on a regular basis. In which case they can inform you about that and let you know what the seizures look like and how they're being worked up by the neurologist. Some patients can have can report an aura similar to what people who have migraines will report before the migraine comes on. But generally speaking, the patients will enter a blank stare, maybe even become confused just prior to going into a seizure. Of course, if this happens, you'll want to keep the patient and the staff safe. You'll want to get all instruments out of the mouth and move all trays and instrument stands away from the patient. If the patient is secure in the chair, it's not necessary to move them to the floor, but that's definitely an option if they're at risk of falling or if you have the chair raised pretty high. Whether or not to call 911 depends on that particular case. If a patient has had seizures on a regular basis, and they're being worked up by a physician, it may not be a true emergency. On the other hand, if this is their first seizure or their seizures have been controlled for several years and they have one, then it may be the case that an emergency call would be necessary. So most seizures are self-limiting. If you just keep the patient safe during the seizure, it will sort of terminate on its own. In some cases, patients can have seizures that last beyond 5 minutes, in which case it becomes more dangerous in terms of risk to their actual brain, having permanent effects. in these cases, you will want to try to terminate the seizure through medication. Valium used to be the commonly recommended drug, but I think most providers, especially those who do sedation, will more than likely have Versed in their office and not Valium. And Versed is the same drug category, benzodiazepine, and it can be used to the same effect. It can be given as an intramuscular injection, similar to the EpiPen, although there's not a manufactured pre-dosed version of it. In kids or if you're not comfortable with an intramuscular injection, you can also give it through intranasal or transbuccal routes, as you can see in the pictures here. All right, probably the most common emergency that we see in our office would be syncope, or basically a patient fainting. It's usually a vasovagal response, which means that we see it in younger patients, usually in their teens or 20s. This is when the vasculature is more flexible, and they're actually able to have an episode like this. It may be preceded by nausea, faintness, feeling of anxiety prior to the patient passing out. If this happens, often just laying them in Trendelenburg is enough to correct it. Usually the patients come to within a few minutes. Of course, you'd want to place the patient on oxygen and monitors. You can place a cold washcloth on the forehead or the back of the neck. And you can use the ammonia inhalants as well. I haven't had to use an ammonia inhalant to snap a patient out of a fainting spell, but it's definitely something that you should have in your emergency kit to use if needed. Sometimes syncope can be preceded by seizure-like activity. Essentially, patient passes out because their brain isn't getting enough blood flow. And in that case, you can have uncontrolled cerebral activity, which can mimic a seizure, but it's usually extremely short-lived. And of course, the patient will come to a little bit faster. Placing the patient in Trendelenburg does not correct the situation, or use ammonia inhalants and they don't wake up, you can consider a drug overdose. Again, you can give Narcan, and if they are not having an overdose, you will not have done any harm to the patient. And of course, this could also be a case of hypoglycemia or a cardiovascular emergency if the patient does not come to. So hypoglycemia, you often see this in diabetic patients, which is a little ironic because they typically have blood sugars that are too high. But if their medications aren't being taken properly, or they're not following their proper diet restrictions, their blood sugar can go too low. And for the case of the dentists who do sedations, if you have your patients NPO, then they're taking their normal dose of diabetes medications, their blood sugar can go too low. And the symptoms are listed here. Irregular fast heartbeat. They can be very shaky, have anxiety, be a little bit irritable. The last thing here, tingling or numbness of the lips and cheek. This would be something that most of our patients will have. But of course, if they have these symptoms before any local anesthesia is given, then hypoglycemia should be on your differential. And this is one of the more easily treated emergencies. If they are hypoglycemic, you can rub icing either into the vestibule, buccal vestibule, or the floor of the mouth. In those areas, the sugar can be rapidly absorbed. And if this, you can also take the patient's blood sugar at that time as well, if you have a glucometer in the office. And if this is effective, you can give them something sweet to drink or eat, and that normally will help turn their hypoglycemia back around. Next, we'll talk about aspiration. This is unfortunately something that where most of us are at risk of having on a daily basis. We use small instruments and small parts that can easily go down the pharynx. Thankfully, in more than 90% of the cases, the object will enter the digestive tract and pass through. But unfortunately, 7.5% of cases, the object will enter the tracheobronchial tree. Patients are at increased risk for this if they have delayed or incoordinated swallow reflexes, a reduced gag reflex, or lack of protection. This can be patients who have a history of traumatic brain injury, patients who've had stroke, or diabetes. They may not have these protective reflexes to keep the object out of their trachea. And of course, sedated patient will fall into this category. It is important to note that if a patient does have a small object enter their airway, they may be asymptomatic. And if you listen to their heart and lungs, may hear normal breath sounds in both lungs. But one way to determine where the object went definitively would be with plain films, chest x-ray, lateral neck x-ray, and plain abdominal film. So these are x-rays that can be taken at almost any doctor's office, definitely in any emergency room. There's no need for CT scanning or MRI or anything like that. So it's fairly easy, relatively inexpensive way to find out where that object went if the patient does, if you do lose the object down the pharynx. If the object is very large, it can actually obstruct the airway, in which case you would want to perform the Heimlich maneuver. If it's small enough to enter the airway and not cause any immediate breathing issues, then of course the patient will need to have the object retrieved. And that is often through use of a bronchoscope. This is actually something that can be done with local anesthesia, in the hospital setting, though a lot of patients would request sedation for this procedure. But essentially, the physician will use a bronchoscope, which you can see here in the picture. It has sort of a joystick, which you hold in one hand, and your other hand basically guides this tube down the lung. The very tip of that instrument has a light, a camera, and suction to retrieve the object. So this is a sample x-ray showing endodontic file sitting in the left lung here. And this is the file that was eventually retrieved from this patient. So long-term complications, again, a lot of these patients will not have any immediate symptoms of the aspiration, even though the object may be sitting in one of their lungs. But the long-term complication for not treating that would be potential vocal cord paralysis, post-obstructive pneumonia, hemorrhage or lung abscess, or even death. So it's important that if you do lose an object down the patient's throat, that you just find out where it went and treat accordingly. And our last emergency we'll talk about will be a cardiovascular emergency, which will usually present as chest pain. And most chest pain, if you have a very young patient, say their teens or 20s and they have chest pain, it can often be due to anxiety. But definitely in an older adult, I would assume that it's cardiogenic unless proven otherwise. Some more rare things that could cause chest pain would be musculoskeletal pain, PE, pulmonary embolism, heartburn, gallbladder disease. But in an emergency setting or in a dental setting, I would definitely have cardiogenic origin at the top of my list. So there's your chest pain can be, or cardiogenic pain can be one of two forms. One is angina. This is chest pain that can come on. Sometimes it's predictable. A patient will say they get chest pain periodically when they overexert themselves or when they're nervous or anxious. Sometimes it can be unpredictable and sort of just come on, randomly, and that's actually a more dangerous form. But angina is a situation where the coronary arteries are not delivering adequate blood flow, but they are still relatively patent enough to still have some blood move through the system. And angina will usually resolve with nitroglycerin. An MI or heart attack is where that coronary artery is basically fully occluded. In this case, the heart is not getting any blood flow, no oxygen, and that section downstream from the blockage will start to die. So these patients will not respond to nitroglycerin. Their skin will be cool and clammy. You can have the classic symptom of an elephant on their chest, but it can also present as just left arm pain, left jaw pain. And some of those less common symptoms are more common in women than men. So this is the one case where you do not want to give epinephrine. Epinephrine is pretty much very useful in most of our in-office emergencies. For a patient with chest pain, they are probably already releasing enough endogenous epinephrine on their own, so they won't need any help in that regard. But also the epinephrine will increase their heart rate, increase the work of their heart, and if their heart isn't getting enough oxygen, then it's just going to accelerate the death of that muscle tissue. So you want to avoid epinephrine if at all possible. Common acronym to remember is MONA, and that stands for morphine, oxygen, nitroglycerin, and aspirin. The actual order that you administer it will be with the M at the end. So you want to give oxygen first, then nitroglycerin, then the aspirin. And then morphine, most offices don't have morphine. And even in our office where we do sedation routinely, we don't keep morphine, stocked. So the morphine is basically to keep the patient comfortable and to decrease anxiety. So nitrous oxide would be a reasonable substitute in the dental setting. So nitroglycerin, this dilates the blood vessels, including the coronary arteries. In most emergency kits, you'll find it in one of two forms, either as a spray, which case you spray it under the tongue every 5 minutes, or as dissolving tabs, which you place under the patient's tongue. And with both of these, you can repeat every 5 minutes for up to 3 doses. Hopefully by that third dose, you've already called 911 because this is a situation where it's not really effective. And if it takes them longer than 15 minutes to get there, I would probably continue to administer it every 5 minutes, but definitely something you'll want to have available for a patient with chest pain. And of course, if it is the big one, if it is a myocardial infarction, the nitroglycerin isn't working, the patient continues to deteriorate, you will want to go through your ACLS algorithm and treat accordingly. So this is, of course, material for a whole nother lecture, but the same principles will apply. You want to administer oxygen, call 911, keep detailed records, and have a defibrillator available, or AED, which takes a lot of the guesswork out of reading the cardiac rhythm and sort of knowing when to shock, when not to. It's almost like a life hack to have an AED in the office. So I would definitely have that available for this type of emergency. And that is it for my presentation. Thank you everyone for giving me an hour of your day off.
Thanks, Maynard. That was great. Appreciate it. We do have a few questions. First question is, how effective do you think it is to have a risk management plan for an office to implement and follow? For example, do like a code scenario if an emergency is taking place, etc. I think it's good to do this every quarter. Thankfully, we don't typically encounter emergencies in our office, which is great, but it also means that we need constant reinforcement and, practice with mock scenarios. So it's nice to every quarter kind of go over a few emergency scenarios, let the office staff become familiar with where the emergency medications are stored, how to operate the portable oxygen unit, make sure all the connections are working. in our own office, I mean, not Virginia Oral and Facial Surgery, but previously, when we would do these drills, we'd find that certain things like the bag on the on the oxygen delivery system would be dry rotted, or we'd find that the mask that we had did not fit the connection on the portable oxygen unit. So just simple things like that. It's good to just go through that emergency because those are things that you, of course, would want to discover before you actually need those items. So, and it's normally something that's easily done over lunch, and half hour of a lunch schedule would be all that you need. And I'd have it recorded so that if you ever did need to prove that your office was prepared, you do have everything recorded in written form.
Okay, next question. Any alternatives to Benadryl that are good? I have a few patients who are allergic to Benadryl, and it says confirmed allergy in parentheses.
Gosh, I have a few patients with Benadryl allergies as well. I have not had to encounter an issue like that. I know there's other antihistamines available, but I'm not familiar with whether they come in injectable form or not. Yeah, I'm not sure about that specific scenario.
Any absolute contraindications to Narcan? Can it be given in patients on active methadone therapy?
I would say if you suspect someone to have a narcotic overdose, I would give Narcan. There's always a risk, again, that you basically put them into an immediate withdrawal situation. Narcotic withdrawal, unlike alcohol withdrawal, is not life-threatening. So, I mean, it may cause the patient misery, but at the end of the day, if you save their life, then it's worth it. But unlike an alcohol withdrawal, opioid withdrawal is not life-threatening. So I would use it if you still suspect an overdose.
If your patient has a syncopal episode prior to initiating treatment and the situation resolves, do you or should you proceed with the procedure?
That is I would say that's up to the provider. It depends on the patient, how healthy they are, and the procedure that you're about to perform. It would, if you're doing an emergency procedure, or if they're a young, healthy person, or if they have a history of fainting at dental appointments in general, you may be okay to proceed. If there's any doubt, or if they have questionable medical history, or if you just want to play it safe, you could reschedule. But often, I mean, if I'm doing something routine, taking out one or two teeth, and it's a relatively young person, I'll proceed with treatment. I'll keep them on more monitors than I would otherwise, have them on, put the EKG leads on, blood pressure cuff, pulse ox, but normally those patients do just fine.
And just quickly back to that Benadryl question, certainly a corticosteroid would also be an option there.
Yes, the steroids take longer to work, but yeah, definitely that does help in an allergic reaction.